My name is Lauren King, Chief Evangelist for Trust AI, and this is part 3 with Dr. Stephen Feit. For this final episode, I want to explore the areas of malpractice risk that rarely get addressed. So I'm talking more about the things that sit underneath the surface of a case long before an incident ever happens. So welcome back, Dr. Feit. I'm sad we're closing out this series, but something tells me we're going to create a new series with you on a different topic because this one has been so well received.
Yes, good to be with you again, Lauren. So ready to go.
All right, let's dive in. So, in your experience, how much of malpractice exposure comes from the clinician's clinical judgment calls? So, not their mistakes, but the discretionary decisions that sit in the gray areas of dentistry.
Yeah, well, that's a very good point. You know, we all have to be aware that we treatment plan to our personal strengths. So some may not like TMJ treatment, let's say, or they don't have the training, and then they'll look through that and just go ahead and treat the case. So now you have errors of omission. If you don't examine for something, even though you didn't do anything wrong, you may have omitted. So if there's periodontal disease, this is the most basic example everyone can identify and understand. There are 7 millimeter pockets, pus, bleeding, all that kind of stuff, and there's a failure to refer, right? So it's an omission. You went ahead and made some beautiful crowns. They fit great. You're well above the standard of care with the procedures that you imparted for your patient, but the failure to diagnose or the failure to address an issue puts you below the standard of care. So you have to be very cognizant and aware, hey, I got to look at the whole system. How are the muscles? How's the TM joint? Even if you don't treat certain areas of the system, then it would be obviously necessary and in your best interest all at once to make the appropriate referral. So if you notice someone had a heart murmur, well, you're not going to treat, I'm not going to treat that. I'm not skilled. I'm going to make the appropriate referral. Or if there's basal cell carcinoma on the cheek, I'm not equipped either to treat that. So that would go to a dermatologist, let's say, or whatever they want to do. So you have to be very aware that just because you don't do it, you don't treat it, doesn't mean you shouldn't identify it.
I see. Yeah, my hygiene brain comes on when you say that, and I think about total body health and the oral systemic link. And anytime I have a patient where I'm seeing them consistently, they're telling me I'm doing everything I'm supposed to do. Their home care is great. They're coming into their appointments. Everything's great. But there's still a significant amount of inflammation. There's low plaque, but they're bleeding like a stuck pig. And I know, as someone that has studied the oral systemic link, your body is using your mouth to try and tell me that something else is going on. And it's my job to make sure that I educate you on this, number one, but also that I tell you how we find out. If we're doing everything we're supposed to on both sides, what it might mean is it's time to go get your blood work done. And let's make sure that everything systemically is going on because I think that there might be something underlying that we can't see. So it's like if a clinician isn't in the place of feeling the confidence to voice that to their patient, does that then become their fault? Or maybe they're in an office that doesn't allow them to speak to their patients like that because they think that you're overstepping or something like that,
Well, if you're in an office like that, perhaps you should look for a new office,
right?
candidly, right? Because really the ethics, integrity, and the way that you nurture and treat your client, your patient is your client. Their interest is highest, best, and only. That's the definition of a client. A customer is just someone you want to sell and get out the door. So it's a matter of how you want to approach it. Yeah, I don't think you have a choice. Medical
Yeah.
legally, they're a client, and so if your quote unquote boss or whoever is running your clinic is not allowing you to be candid with your client or your patient, you should run because now you're really in a box and you have no way out. You're the rock in the hard place, I guess you'd say. So, you're never wrong when you do the right thing. So, maybe going to that office isn't necessarily the right thing. But, it's hopefully very rare that someone's in that situation. And, it's just, I always say you want to be a human being. People say, what do you do for a living? Everyone says, well, I'm a fireman. I'm a dentist. I'm a periodontist. No, no, no. I'm a human being trained as a prosthodontist, right? I wasn't born a prosthodontist, but I'm a
Word
husband,
talk.
I'm a father, I restore old cars, I play sports.
Mhm.
I do a lot of different things. So it's just one part of my life.
Right. Absolutely. All right. So let's dive into more of the standard of care, like the path that we're on, but also the documentation side of it. So how should clinicians think about the fact that standard of care is not a fixed document, like we've talked about before, but something that's interpreted through expert opinion? So where do you see the biggest gaps between how clinicians think the standard is defined and how it's actually elevated or evaluated legally?
Okay, so this is the most difficult question to answer in deposition when they'll say, "Doctor, what is the standard of care?" There is, what's scary is there is no set definition that everyone can point to and say, this is the standard of care definition. So the best one that I've encountered that I've never gotten pushback on is what a similar dentist in a similar community setting would do for a similar patient with a similar problem to the patient that you're treating. So if you're in a rural community, your resources are vastly different than maybe downtown Manhattan or Chicago or Boston, because there you have a multitude of super specialists, that are very narrowly trained versus somewhere in the middle of the rural area, middle of the country where, you really have to do
Yeah.
much more because there just aren't the resources available. So that's the first thing. And so now it's up to each person who's listening to this and who's licensed to determine what their standard of care is. So do you want to just be at the minimum standard? Most people would say no, not knowingly. You don't want to be knowingly at the minimum. So you want to elevate your standard of care. So you want to do better. So you asked me last time about chart notes, and I went off on a bit of a tangent. And after we were finished, it was gnawing at me that I didn't really give an exact answer. And hopefully people are coming back to listen to this third one. And what I said last time was there has never been a chart that I've been lucky enough to get as helping defense that was really defensible. Like the chart notes are horrible. They're sketchy. They're incomplete. They're ambiguous, missing teeth numbers or materials and how they did things. So what's the ideal chart note? Well, to me, of course, this is subjective, but for me, it's SOAP. We learn this in dental school. It's quite simple. Write down in quotes what the patient says. My upper left back tooth is killing me. And that's what you write. And if they curse, I put the curse word in
Do
in the
you?
quote. Yeah. Well, it points to state of mind.
Right.
How empathetic, are
Yeah.
you? Like, they're really hurting. So why not demonstrate how bad it was? And that's the subjective, that's the S. And then, of course, the objective would be what the clinical exam reveals. And then the assessment, SOA. A is assessment. Okay, what's going on? What do you think? What's the differential diagnosis? And then the P is the plan. What did you actually do? Administered X number of carpules of whatever anesthetic, and then what you proceeded to do, post-op instructions given, all that kind of stuff. And then, in my opinion, I make my post-op calls on the way home typically, or sometimes right before I leave the office.
Mhm.
And it's an 8-second post-op call. Hey, Mrs. Smith, it's Steve Feit. And they're like, who? Dr. Steve Feit? Because I don't want to be doctor, right? I want to be a friend calling and asking, hey, I'm thinking of you. You're on my mind. I just wanted to give you a quick call. How you doing? My God, I can't believe you called. I mean, everyone listening to this does this. This is for the people who are not listening to this, right? Those are the people that are really most needing to hear this. So, I don't know it all, but, the people listening certainly do know a lot. And I definitely don't want to talk down anybody. So that's what it is, 8 seconds. Then the next morning, or right then and there, I'll put in my chart note, stop call. Spoke with patient. Patient is good spirits, very pleased. Did I ask for a referral? Asked for referral. Patient said they will refer, blah, blah, blah. So it shows that there was acceptance. They're happy. If I didn't ask for a referral, I don't note it. There's an old saying in front of the jury or in deposition, if it's not written in the chart, it didn't happen. But listen, and I look back at some of my notes and I think they're exquisitely complete, and they're not. They're
Right.
just not. You can't write everything. You're in between patients. You're on the fly. It's busy. You have to get home. Look, we're all human beings. It happens.
Yeah, absolutely. I feel like that's one of the things that I'm so excited about in terms of the scribe side of what we're doing in technology, in terms of every single thing is recorded down to the pauses in between and what is being said, and it immediately becomes a legal document. Right. So it's like the faster you implement these things, while they might be scary, and while you're like, I don't want to let go of the reins and let a piece of technology make sure that everything is documented A to Z and dotting all the I's and crossing all the T's. It's like, well, if you don't, the risk is much higher, right? The risk of the fallacy, or like the inaccuracy of a human being notating something, is much, much higher than technology that has literally been programmed to do just that and to do it flawlessly at on top of that, right?
Yeah, that's the most powerful thing about this AI is so many times I'll read a deposition of the defendant of the dentist, and they'll say, "I meant to write that in the chart. That really did happen." Because the opposing
Yeah.
counsel, they get very antagonistic because they get paid only if they prevail. So it becomes a very adversarial, very aggressive relationship uh,
Mm.
bet- across the table, and I'm involved in that. I get most of that aggression towards me.
Which I can only imagine, if you're the clinician being on the other side of that, it's too late, right?
Yeah. Yes,
Unfortunately,
it's way too late.
it's way too late.
Yeah, listen, there's many reasons a patient will decide to pick up the phone and call an attorney. And think about it. To call an attorney, think about what that patient had to go through. They had to ask some friends. Now they're telling the story about us, the dentist, and what happened. So now that's a really bad thing. Which lawyer, which attorney, which law firm, who's the best, who's going to help me and get me the most money. So now they're calling all over town using the story, the dentist name. It's a disaster. And then by the time they pick one, now you're off to the races. They want to get an affidavit from the opposed from a expert witness, and once they have the affidavit, they file. Well, they don't file. They request records,
Mhm.
and then if there's probable cause, as we discussed in the first one, well, now they'll file in court, and that's public record. Yeah, it's public record.
That's just, it blows my mind. I feel for clinicians, right? It's like it's such a big responsibility, but at the end of the day, we kind of signed up for this. I want to say, but at the same time, I don't want to say as a clinician, but I feel like the cards are high, high, high stacked against us right now with the current documentation technology that exists to this day, right?
Right. Yeah,
So
but go
go
ahead.
ahead. Go ahead.
Well, with the AI, it's going to reverse that. Right
Right.
now, you're empowered.
Right. Absolutely. I couldn't agree with you more. So I'm going to segue a bit into more of like the internal culture side of a dental practice and how that can trigger something involved in malpractice. But how much does the internal culture of a dental practice influence the outcome of a malpractice case? So what are the cultural patterns that you've observed in the cases that you've seen that tend to make practices more vulnerable?
Right. That's an amazing question, and I'll tell you why. Because in my opinion, that's the cornerstone or the foundation or the basis of which
Really?
to mitigate legal malpractice. I think it's the cornerstone for a good family, for a loving, kind family. I think it's the cornerstone for a good friendship. The culture, the way we feel towards others, treat others, common courtesy, unfortunately, isn't so common. That's the cliche, but it's true. So most of the times these litigious patients, either they're just litigious, and some people are, they're just trying to make a living suing everybody, and they're out there. They just move around. It's either they felt slighted and then they didn't feel heard, and they want a pound of flesh. And some of them will take the money and donate it to charity. It had nothing to do with the money. Some of them will trigger a board action because they really want a pound of flesh, because now they're going after your livelihood. Because if they prevail with the board has the ability to suspend or revoke a license. And you get it's a huge hurt, because now you can't make a living.
Hmm.
So culture, like real estate, location, 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 right? What do you do before the patient arrives? What do you do when the patient arrives? So I'll tell you that I bartended at the Playboy Hotel and Casino between college and dental school.
Okay.
It's a very long story. I'll make it very short. It is colorful. But what happened was I looked like the lady's son who hired me. She turned his picture around, and so you need luck, right? Because it was hard to get that. I was on the second floor in what was called the Playmate Lounge. I was a bartender. I had gone to bartending school, and I had a resume and a lot of different positions, so I was very well trained. Um, and so what I received it during that experience was really an MBA. So let me explain.
Interesting.
Yeah, so oddly enough, the ladies were not all that attractive. The Tropicana, they had attractive ladies. So I could not gamble in the casino I worked in. I was fingerprinted and with the
Interesting.
Casino Control Commission. They have cameras everywhere, of course, they did, but there's no clocks. The air conditioning is so exquisitely regulated. They had the one-armed bandits had metal bins with metal coins, so you had the sound of the coins. Most people like to gamble in the corner, hidden. All the one-armed bandits hit by the doors so that people hear the coins and they say, hey, if they did it, maybe I'll do it. The psychology, they're giving you liquor, changing your reality. So you don't gamble dollar bills, you gamble chips, right? So every aspect of the experience, the way it smelled, the smell that they pumped
Hmm.
in those days, you could smoke. This was 1983.
Hmm.
So you could smoke anywhere you wanted. They removed the smoke, so it was as comfortable as possible.
Hmm.
No windows, like I said. You don't know what time of day it is. It's a time warp.
Hmm.
So I designed my dental office like that. I controlled every single sense, how it smelled, how it looked, how it flowed. I never used a front desk. I picked up from Omar Reed, who did this in the 1970s, but I didn't enter practice till 1987. So our patients were like treated like guests. I'm not saying everyone should do this, but this is what I've done. If I know my lady, we call them care nurses. So they're an assistant and a front desk all in one. They're all cross trained. So if someone goes on vacations, there's somebody there that can do every single duty that's needed. So let's say Vanessa's the care nurse for the patient coming in at this hour. She'll be waiting in the waiting room if she can, and greet them at the door as if it was your home. Bring them to the treatment room. We would take payment if it was due, or usually they're prepaid. Sit down, remind them of the treatment they're going to receive. I come in and render the care. Then they're scheduled if there's a follow-up visit or crown insert or something like that, and they leave. Everything is done in private. There's no overhear in the waiting room. No one knows what they just had. They're safe and secure in their own private room, and they just leave. So then what happens with the other care nurse? Well, she's going to do the same thing for the next patient. So we had phones in every treatment room because I'm in South Florida. We have an older population. I wanted to be 3 feet from a phone if needed to call 911.
Hmm.
So that was a safety feature for our patients. We only had to call 911 once or twice. We thought someone was having a stroke. It was just a bad migraine. They refused transport. They actually left the office when they saw us call 911. I had to chase them down in the parking lot to sit them down.
Oh my gosh.
And then another one, we thought one of my ladies thought died, and they were just sleeping, so they
Uh-huh.
they didn't they didn't properly assess. So I said we got to cancel 911.
Oh my gosh.
Yeah, but it's all culture. So if every time the patient comes in, they see the same care nurse, that care nurse gets to know their spouse's name,
Yeah.
what's going on in their life. They can ask for referrals. And then the other care nurse never sees that patient. So instead of having one front desk and one assistant, I had two people that were totally cross trained. Because if they're scheduling the appointment, and then people say, well, who answered the phone? I have a phone in every treatment room. There's a computer in every treatment room. The front desk is in every treatment room. There's a phone in sterilization in the little laboratory that we had.
Mhm.
There's a phone in every place in the office except the bathroom. Um, so when you are that attentive to your, and then we followed a courtesy system, and that's a whole podcast in itself. And we also followed three rules. If someone has a complaint, there's three distinct steps in managing a complaint. I didn't invent this, I just read it, but you listen and you be quiet. Let them talk it out. So much so that when they're done talking, they'll say, do you have anything to say? And I say, well, Mrs. Smith, I didn't want to interrupt you. Listening is active. And I tell them that listening is active. And I'm actively listening to you. I'm not distracted. I'm focused on you. So the second step is to restate what they'd said. So if I'm listening correctly and I get you, this is what you're concerned for. And you summarize it quickly. And now they feel heard. And you can almost see them exhale and the shoulders relax and all the little things that put them at ease. And I said, I'm on the same page with you. So now I'm not across the table. I got my hand around their shoulder figuratively, and I say, here's how we're going to solve this.
Mhm.
And then you make restitution, but you do it swiftly right then and there and with an apology. And an apology is not an admission of guilt. An apology says, listen, and I'll say this verbally, I'm sorry that this issue is coming between our friendship. So let's remove this issue as swiftly as we can. This is how I think would be best, but I'm open to your suggestion. Now, I just took their finger off the trigger. They were wicked angry and they are now heard. I restate to verify that I am understanding what their concern is. And now we're into solution mode. Now, there are those people who love, they say a winner finds a solution in every problem and a loser finds a problem in every solution.
Mhm.
There are a lot of losers that really love to dwell because, their life is empty. There's a lot of psychological factors here. They're getting attention. Maybe they live alone. Their husband, their spouse just passed away. These things are real. So you have to be very empathetic and nurturing and sincere because they'll pick up on if you're just like, okay, step one, step two. And then you say, well, is this solution adequate for you? Is it going to meet your expectations? Well, I would like something else. Well, why did this happen? Why did this happen? And I say, listen, we have a choice. We can dwell on the problem or we can implement a solution.
Mhm.
How would you like to proceed? And then some of them just want to stay on the problem. So you just have to I just restate it
Mhm.
until they're sick of hearing it. Okay, let's fix it. Okay. Now we're on. And you can make a stronger relationship for it. So instead of them picking up the lawyer, we're going to hand them two business cards and say, hey, listen, we just solved something that really upset you. We're here for you. Would you mind? We would love to help your friends. Now, if you like the person, we didn't ask everybody to refer. We had A, B, C, and D patients about, that's a whole nother podcast, but another, like a couple years in, I
Mhm.
dismissed all the C's and D's. And so I was working with A's and B's for so long. So I didn't have to dismiss too many. But we took referrals from other specialists, and a lot of them would dump some of their C's and D's on us. And we would, what we call train. There's a whole module when I was doing consulting, and I still do. There's a whole module on training your customer. All right. And so like every business, because I consult different businesses as well, but it's all the same principles. They're all human beings. We all have the same wants and desires, and you want to be made felt to be important and heard and acknowledged and that kind of thing. But if I have a wicked nasty patient in my office and I have a really nice patient, I'll let the nasty one wait. I'll bring the nice one back, even if their appointment time is after the nasty one, because I'm gonna nurture. I'm gonna over deliver for the really nice one, because I'm gonna ask that person for referrals. But the nasty one, I don't want the referrals anyway. And chances are they need psychogenic meds, and they they need a psychiatrist, and
They need a
this
lot.
this I don't want to deal with it. The old saying, through the front door of the office, everybody makes us happy, some on the way in and others on the way out. Well, you look at the schedule and you see someone coming in and you're like, oh my God. Well, that's the person to dismiss. But
Yeah.
that's a whole nother podcast on how to dismiss appropriately so you don't trigger a legal action, because that's a form of rejection. That's a major form of rejection that can be interpreted it is very personal, right?
Hmm.
Yeah.
Absolutely. I feel like that's a good segue into the role of clinical intuition, which is what I want to talk to you about before we segue out. So, from your perspective, of course, how much weight should clinicians give to their intuition, so that gut feeling that something's off, right? This patient is going to be a problem. I don't feel safe in front of this patient. I feel like I can't tell this patient anything. And even when everything appears clinically appropriate on paper, it feels off.
Yes. Always follow your intuition, your gut. Women have what intuition, men follow their gut, or whatever, vice versa, the hair on your neck or whatever you want to call it. But almost invariably, when I debrief the dentist that I'm helping defend, and the action is terminated, either settled or just ended, I'll say, what do you think the major problem was? And almost invariably, usually I would think they'd say, oh, I should have done the crown better. I should have done this better. They're like, I knew I should have never touched that person.
Yes. I've
Yeah.
said that.
Hmm.
Yes.
Yeah. And it's almost without exception, because most of the time the dentistry isn't bad. It's not bad. We're all really well trained, all of us. Look, I have had cases with open margins that are radiographically evident, so they're significantly open margins. Okay, that's a biomechanical, you got to redo that case one way or the other, but it shouldn't have ever been inserted, right? Then it would have never been a malpractice practice action. And to that point, I've seen in numerous cases that the patient was unhappy with the PFM bridge, but the dentist put in the PFM bridge as an interim because they said it looked better than the provisionals. And then they yeah, they went to make a new PFM bridge, let's say. And meanwhile, the patient's wearing this deficient bridge. And then the patient started a malpractice action
Oh my
because
god.
they may have gone to another dentist or something. My patients travel. They have a dentist in Florida. They have a dentist up north. So there's always eyes on whatever I'm doing. That's never happened to me, fortunately. And I would tell you if it did, because I would just be honest. But I was trained that the provisionals are a prototype. You nail the prototype if it's an anterior bridge, especially. You work out all the aesthetics and everything, because it's so easy to sculpt acrylic instead of shaping porcelain or some other material that's wicked hard. So what happens is once they approve the provisional, then we make a model of the provisional, right? And then we ask the laboratory to make a matrix, and we're going to try to copy that as closely as possible. So work everything out in the provisional. But I've seen at least a half a dozen cases, at least, where they put in the PFM bridge that they knew that they were not going to leave in, and they used it as a temporary. No, that's what happens in the eyes of the court, that you accepted that fit, even though it wasn't a good fit, right? It was below the standard. And so you're better off just keeping in the provisional, because patients will say, well, I have a wedding. This is what one of them said. I had a wedding and I told the dentist, no, I want to wear this for the wedding, even though I knew it didn't fit. And then they started drinking some ice cold drink at the wedding, and they had such pain, and they were miserable at the wedding, and you're off to the races. Yeah, it's
Oh my
bad.
and I feel like it just snowballs.
Yeah, once the horses are out of the barn, you're cooked. And Also know this, if you hear a patient says, I think I'm going to call an attorney, the dentist must, it's a contractual must, contact their malpractice carrier immediately. And
Really?
yes, otherwise they're at risk that the malpractice carrier has a loophole to not cover, support, and defend the action of that dentist, because if they say they contact the patient and they say things that are not supposed to have been said because counsel at the malpractice carrier didn't have an opportunity to coach the dentist on what to do, how to do it, and what to say,
Hmm.
then they're going to say, well, you put the malpractice carrier at risk and in a hole to do the defense, and therefore we're not going to defend you. And I've seen a couple
What?
cases. Yeah, it's serious.
I guarantee you, majority of our profession does not know that.
No, they do not know that. And then the other thing that everyone should understand is that there is a legal department of whatever malpractice carrier you have, and that if you had a question, let's say you want to dismiss a patient and you're in the middle of treatment, simply pick up the phone, call and ask for the lawyer. There is a lawyer, an attorney that's on staff, and 9 times out of 10, you're not going to get the attorney on the line, but they will call you back. Usually they call back by end of day, and you run the scenario. Hey, I have this lady. I got a 6 unit bridge. I got this. I can't take it. I want to give her a refund. I want her to sign a release. Like, how do I get rid of this? I am not sleeping at night. I just want to kick it. And you got to get a release. If you ever return any funds, you must get a release. Life is a relationship. The verbal skills are, look, I'm happy to give you back your money. I'm sorry things didn't work out. I wish it did. The only way I can help you now is to do this. Of course, amount my lab bill and all this other stuff, but I'm happy to make you happy. Here's a release. In the release is a confidentiality agreement, which is one of the most important aspects. They can't put a 1-star review. They can't be shouting from the mountaintop about how bad Dr. X is and that he gave me back his money. It also states that it is not an admission of guilt that anything was done below the standard or wrong. And it also says that you will not come after me, my practice, my office, my staff, my family, my heirs, anybody and anything. And I would highly recommend that you contact your malpractice carrier and ask them for that release. If in the event you were to return any fee, you have that release in your drawer, you use it. Use their release because they want to be included in the fact that the patient cannot go after the insurance company. So they're going to be included. They're going to be very thorough in the release.
Got it.
So
Wow. There's so much, and it's terrifying to think that there's so many of our colleagues and so many people in our profession that are practicing every single day, and they have no idea that they're basically putting their hand in a mousetrap every single
yes.
day.
Yes.
It's scary, doc. That's scary. But
Yes.
I'm thankful that we have people like you that are willing to educate on a topic that most people don't want to talk about. Like I see that in when I talk about human trafficking, right? It's like it's a dark subject. People don't want to talk about it. Nobody wants to talk about getting sued until they're being sued. Nobody wants to talk about trafficking until they know someone that's been trafficked or something very, very close to them, right? And I'm sure you tell people just like I tell people, then it's too late, right? We're trying to catch you before these become real life scenarios because we don't want it to happen to you. I know it's not what you want to talk about, but the reality is you're living this day in, day out, and your risk for it is high due to lack of education. Would you
Yeah.
agree?
Absolutely. And it goes back to the culture that you brought up. Yeah, it takes a little while for the practices that I help nurture their culture. But if you don't create your culture, guess what? It's created for you.
Hmm.
And a lot of dentists that I rub shoulders with at meetings and that type of thing, they'll be complaining about their team, or they call it a staff, right? Their staff, they call it the patients are horrible, they're garbage. There's no garbage human being. Human beings just need to be nurtured or trained. You don't know what happened in their past and what brought them. And also, they're at their absolute worst coming into the dental office. We're going to invade their personal space. We're going to impart all this sharp objects, needles and everything else, and they have to sit there and take it and then pay for it, right? So, they're not the happiest, they're nervous, their personality may not be who they really are, they're just they're under such extreme duress, So you have to nurture that. So you can take a C patient and make it an A patient. And then we have to define what is an A patient, what is a C patient, what's a B patient, and all that kind of stuff. But I want you to guide me.
No, now I want to wrap everything up by asking if there's anything over the last 3 episodes, this being the 3rd, anything that you think clinicians need to know that we haven't talked about that is just pertinent, or even thinking futuristically with technology that's coming out, anything that you would say, "Hey, I wish I knew this. You need to know this."
Yeah, I wish I had the AI chart notes. Amazing, just amazing. Because think about it, you're in deposition and they ask, how are these notes derived?
Mhm.
It's objective. These notes are not my opinion. And look, I have seen notes where the dentist is covering their tracks, and it's so obvious, so obvious.
What makes it obvious?
The way they word things and that they allude to things that happened in the past that shouldn't be of issue in that particular chart note. I have seen people alter charts. They get white out, or they change something, or they changed a page and they retyped. And once you do one thing that's unethical, you're cooked. Nothing you say or do is believable. Your entire testimony is impugned. You are done. It's just a matter of how much you're going to settle for. So as much as you want to embellish a chart note, oh my God, even though it really happened, if you do it, with the timestamps and all the other forensic capability that they can get into the bowels of the PMS, the system, you're done. They will check things. And if you're still using paper, I know experts that are handwriting experts that they can tell if you did something the same time or different time and came
Wow.
back, because your body's different. You're in a different mindset. Also, they can time date ink. They know if it's fresher ink or older ink, and that the ink's date doesn't match up. What you think that they will never find out and discover, they already know. You're done. So you got to live by it, give them what you got to give them, and just go from there. But the best thing is not to get that notice. I get notices all the time because I treat a lot of complex patients as a specialist in prosthodontics. And, I didn't know that they're suing their previous dentist. So I get a subpoena and I'm standing there, and they put the paper on you. Okay, you've been served. I said, I've been served. And the first thing I look at is who's the defendant? Who's the defendant? Okay, it's not me. Well, it's some poor guy,
Yeah.
gal with a DMD, DDS. Oh gosh, here we go. So they're asking for my records as a subsequent treater because they want to see the state of the condition of the situation when they first arrived at my office. Then they're going to depose me. They're going to try to get me to implicate the actions of the previous dentist. And the only good thing with me is I'm very comfortable in under oath. I'm very comfortable. Like it gets so cantankerous that I've had to say to the court, with the court reporter reporting, I say to the attorney, I'm going to tell you this: if you're rude to me, I'm going to escalate. And if you escalate, I'll escalate worse. And you want to get if you I will get it to a level of ugly that you have never dreamed of. So I'm very defensive of my people. I'm defending this dentist and his family and his work and everything. And we're going to keep it very civilized. So I kind of enjoy the confrontation. It sounds weird, but I'm confrontationally
Well, no, I
tolerant.
mean, I think those are the disruptors in the field, or in the topic or the issue. I think that people like that are very needed, because there's things that need to be said that people are not willing to say. We need those people that are like, "No, this isn't right."
Yeah, and so many of these experts that are working for the plaintiff, they robo sign. They don't even read the complaint. They don't read anything. They just sign that there's cause, and then we have to go down the road and sort things out, and then it's dismissed. And meanwhile, the poor defendant hasn't slept in months. it's hours of work. Malpractice premiums go up because they pay me, they pay the attorneys. It's horrible. Yeah.
My goodness. I have learned so much as a clinician, as on the business side, on the legal side. I think that just these 3 episodes alone could equip you with armor that is much, much needed in a profession where our patients naturally walk in the door and their defenses are already up to not trust us, right? It's like I would say we're probably one of the only professions that we can say majority of our patients do not trust us, nor do they like us. So we're already starting from a negative place. And I don't think that in any of our programs currently, hopefully this will change, but in any of our dental programs or dental hygiene programs, we're not talking about this enough. I don't feel like we're not equipping our clinicians with the armor that they need to treat a human being on a day to day basis. So I want to thank you for spending 3 episodes worth of time with us at Trust AI and Voices of Dental AI helping us do this.
My pleasure. It's been an honor, and I've enjoyed the interaction. Thank you so much for having me.
Absolutely.